This is Selma Schimmel for the Group Room at the annual San Antonio Breast Cancer Symposium, joined now by Dr. Julie Gralow, the Jill Bennett Professor and Director of Breast Medical Oncology at the University of Washington and the Seattle Cancer Alliance, also a member of the Fred Hutchinson Cancer Research Center. Hello, Dr. Gralow.
Hi, Selma.
Thank you for once again, Dr. Gralow, joining us, because our coverage at San Antonio would never be the same without you, and every year you make time to come sit with us.
Well, it's always a highlight of my San Antonio experience to review a few of the abstracts with you.
Let's start with endocrine therapy and some of the news that we have for our metastatic cancer patients.
We had a couple of trials in the endocrine therapy arena for metastatic patients. We had a presentation of the CONFIRM trial, which was a trial of 2 different doses of a drug called fulvestrant. So it's kind of the third class of endocrine therapy that we have in treating metastatic breast cancer. We have the SERMs, selective estrogen receptor modulators like tamoxifen. We have the aromatase inhibitors, and then this third newer class, the SERDs, the selective estrogen receptor downregulators, and fulvestrant's in that class. Fulvestrant, it's a powerful drug. It's given intramuscularly, not orally. So that's important. It's given about once a month. And the CONFIRM trial that was presented was showing an updated review of 2 different doses. It got FDA approved at a dose of 250 milligrams. But subsequently, we had some hints that a higher dose would do better. So the CONFIRM trial compared head-on a 250 milligram dose with a 500 milligram dose and showed not only was response improved and progression-free survival, the time that the tumor doesn't grow, but that with an update, the overall survival looks very strong as well. So this doesn't really change clinical practice because actually not too long ago we changed the dose, the FDA-approved dose of fulvestrant to 500 milligrams, but it really supports that this is the dose we should be using, and that's exciting for our patients.
And how long is a patient on this therapy?
Well, if you have metastatic breast cancer, you're generally on a therapy until your tumor either progresses or until you can't tolerate that therapy anymore. So until we can figure out how to get cures where you can stop all therapy and the tumor is eliminated and doesn't grow back, in the metastatic setting, you're generally on a treatment indefinitely until tumor progression or intolerability.
When you say it's intramuscular injection, is it a painful injection for the patients?
It's a big needle, and now with the new dose, it's actually 2 shots, generally in the buttocks. So most of my patients don't complain a lot about it as long as we warn them that it's a big needle and that it's 2 shots, and it's certainly better than chemotherapy, which is generally, if we didn't have this third class of endocrine agents, we'd frequently be moving to chemo.
What are some of the side effects?
It's a pure anti-estrogen, and so hot flashes and night sweats are a side effect. You can get vaginal dryness from it. If you were on it very long term, you might get some bone loss because estrogen's good for the bones. So it's mostly menopausal symptoms, and certainly no worse than tamoxifen or the aromatase inhibitors.
The difference being some that are used for metastatic disease and some that would be used for less advanced disease.
Right.
Let's talk about any other advances that are being presented here on behalf of endocrine therapy.
I think one of the most exciting trials for estrogen receptor positive metastatic disease was a trial of one of the aromatase inhibitors, letrozole or Femara, and the patients were all given the letrozole and randomized to get a drug in a class called a CDK4/6 inhibitor. So this is a pathway involved in the cell cycle that this agent comes in and inhibits. So it basically blocks cell growth and division by coming in and hitting it. So all patients got the aromatase inhibitor, the Femara. Half the patients got this new agent in this new pathway, and there was a dramatic improvement in progression-free survival from about 7.5 months to somewhere around 25, 26 months for adding this agent. Really
That's
impressive.
really impressive.
Really
yes.
impressive to have that big a difference. Now, this is what we call a randomized phase 2, so it's a smaller number of patients, and statistically it's not as solid or sound. So this trial was done to see if we should invest in a much bigger randomized phase 3 definitive trial to explore this drug. We're really excited about this.
And when does that take off?
It will likely take off very soon based on the exciting difference between the two arms.
So when you see this happen clinically, these are the kind of drugs that often will be approved sooner, fast-tracking drugs when you have this kind of response.
Absolutely. So we're looking at a whole variety of different pathways that partner with the estrogen receptor pathway and can be invoked in estrogen therapy resistance or endocrine resistance. So this is another pathway. There was an mTOR inhibitor called everolimus that was tested in a similar trial design, and we saw the results just last year in the Bolero 2 trial, and that led, we saw the results just last year, has led to everolimus's or Affinitor's approval within a year in treating endocrine resistant metastatic breast cancer. So we can get these drugs approved pretty quickly when the results are very powerful.
And also, the point that you drive home are the changes and the advances happening for women with metastatic disease.
Absolutely. I think women are, in general, living much longer, years and years. We still don't have cures. Or many cures in the metastatic setting. We know we need to do better, and there's clearly a subset that don't have long survival after their metastatic diagnosis. And we've got to keep those women in front of us so that we know we need to work harder and do better.
Thank you, Dr. Gralow. I love our overviews with you. You touch on so many important things, and your research, awfully important.
Thanks for having me, Selma, and thanks for everything that you do for all of your viewers.
Dr. Julie Gralow, the Jill Bennett Professor and Director of Breast Medical Oncology at the University of Washington and the Seattle Cancer Care Alliance, also a member of the Fred Hutchinson Cancer Research Center. Thanks again, Dr. Gralow.
Thanks, Selma.